welcome to the last module of our series entitled Caregiver Connections, Shared Decision Making, and Patient Resources. My name is Dr. Mark Agronin. I'm a geriatric psychiatrist and serve as the Senior Vice President for Behavioral Health at Miami Jewish Health in Miami, Florida. I'm also the Chief Medical Officer for Mind Institute at Miami Jewish Health, which is our Memory Disorder Center. It's been my pleasure and honor to be joined throughout this series with my friend and colleague, Dr. Richard Isaacson. He's the Director of the Alzheimer's Prevention Clinic and Associate Professor of Neurology and the Assistant Dean for Faculty Development at Weill Cornell Medicine and New York Presbyterian in New York City. And Dr. Isaacson, welcome and thank you for sharing these modules with me today.
And look forward to this final module.
Sounds great. I'm just disclosing I do some consulting for Biogen and Eli Lilly. Dr. Isaacson does not have any specific disclosures. The program is provided by the North American Center for Continuing Medical Education and HMP Company and supported by an educational grant from Biogen. And in this final module, we are going to talk about how to competently initiate conversations on difficult topics with patients with early Alzheimer's disease and their caregivers. And we'll share with you some helpful Alzheimer's disease resources that you can in turn share with patients with early Alzheimer's disease and their caregivers. So some of the most common issues and some of the most vexing issues that we deal with in individuals across the entire spectrum of Alzheimer's disease and other forms of dementia, but in particular, sometimes even in early stages, are what we call behavioral and psychological symptoms of dementia. Keep in mind, just as the brain is being damaged and affecting cognitive abilities and function, it's also going to affect mood and behavior. So we see agitation, changes in mood such as depression, mania, anxiety. Apathy is actually one of the most common neuropsychiatric symptoms we see. We also see increases in psychosis and also behavioral changes like intrusive wandering, excessive motor activity, resistance to care, disinhibition, sleep disturbances. And you can imagine that from the perspective of the person, these can be really unsettling and disturbing symptoms. There can be reasons why people end up needing a lot more care and medications, even nursing home placement. And for caregivers, these really impose such a burden. The good news is that there are ways to approach and treat all these, but you have to be able to recognize them and have that ongoing relationship and connection with caregivers to really address them. Put together, we call these behavioral and psychological symptoms of dementia, and it's such an important component of what we do clinically.
And, it's really important not to underestimate the burden of agitation. And I can say that, 15, 20 years ago when Alzheimer's really didn't have much in the way of symptomatic therapies, I really believe back then the burden of agitation in some ways was greater because I just can gauge it by how many phone calls we would get on Monday mornings and how difficult the weekends would be with patients going to the emergency room and really needing extra help with outbursts and wandering and things like that. It's actually estimated that 80 to 90% of patients with dementia will demonstrate some forms of this, and honestly, some of the highest rates are really in the more severely demented patients, especially in nursing homes. Agitation is associated with just not even just so many different things. Just it's not just the actual manifestation, but it's increased healthcare utilization. It's challenging for their loved ones, for the families, for the care providers, whether it's at home or in a nursing home setting. Increased caregiver stress. It's just a terrible additional symptom that oftentimes really is forgotten in the talking about Alzheimer's. It's a very stigmatizing condition. But if we can try to understand that this is an issue, we can at least explore some of the pharmacologic and non-pharmacologic approaches that may be beneficial.
Sharon, what's wrong?
I'm so worried. That thing happened.
What happened? What's wrong?
You know what? That thing happened. That thing we talked about.
I'm not certain. What happened?
I told you,
Hello? Yes, this is Mr. Evans. I need to speak to Dr. Carter. It's about my wife. She's not feeling well, and I've left several messages. I really need to get some guidance. I can't wait 2 weeks for an appointment for her. Can't I talk to a doctor today? Okay, please have him call me back. I waited all day yesterday and no one called. Thank you. Jody? Hi, it's Dad. I don't know what to do. Your mom is upset again and angry. She can't remember anything I tell her. And she fights me on everything. I don't know what I'm doing wrong. I'm trying to help, but nothing is working. I'm just messing things up here. Yes, I tried calling the doctor, but he won't call me back. I can't get an appointment for your mom for 2 weeks. I really need some help here. She's up all night and I'm not sleeping. What should I do?
And this is where we have to engage with the caregivers and really understand what their burden can be. We talked about this in the very first module, that we know caregivers have increased rates of anxiety, insomnia, depression, medical problems, even higher mortality rates amongst caregivers. And think about it, the stress they face, not just in terms of the physical caring for someone and the emotional burden of this, but their enormous financial costs. And we always have to look at the context, because the average caregiver is typically an elderly spouse. They often have their own medical, psychological, and even sometimes their own neurocognitive problems, which are going to make this even more difficult, especially if they don't get a lot of help from family or the resources. But I do want to say the following, because we see this as well. A lot of caregivers thrive in their role. It brings them meaning, it brings them purpose. Even though it's difficult, it can be stressful at times, this is what they want to give to someone. It's someone they love and care for, and all the more reason why they need our role and our involvement in helping them out.
So when it comes to trying to optimize care, there's a lot of important strategies, and it really goes across the spectrum of care. So across that spectrum, we really need to, first of all, clarify the diagnosis. What type of dementia is it? What stage? What are the comorbid conditions? Alzheimer's disease may be the most common form of neurodegenerative dementia, and especially in the even moderate to severe stages, you can certainly have pretty debilitating neuropsychiatric symptoms. But there's a variety of other neurodegenerative dementias that, for example, frontotemporal dementia, that will cause symptoms of behavioral dysfunction earlier, maybe even initially. Dementia with Lewy body can have all sorts of different issues with hallucinations, psychosis, also a little bit earlier. So we need to understand what the diagnosis is, and then we can truly optimize treatment. We talk about cognitive enhancers. We talk about medications that may reduce a person's risk for decline, using antihypertensive medications, using medications for diabetes. And of course, what's the best way to optimize treatment? To consider research studies, because we don't have all the answers here. And, to truly optimize care, it's not just to advance science. I think that's important. I mean, of course, it's advancing science, and that's great. But if a person is truly going to get the best level of care, I think, honestly, every patient with a neurodegenerative dementia should be considering a research trial. So when it comes to addressing the safety of daily life, it's essential to address what are those dangers? What are the potential dangers that can cause something catastrophic? Dr. Gronin and I shared, we've shared many patients, but one I remember very vividly who got in a car accident. She should not have been driving. She was driving in Miami Beach and had a car accident, and it led to a lot of deleterious aspects, from legal, financial, and otherwise. Is there supervision that is, sufficient? And is there care that is well-rounded? And these are really important aspects to optimize care. And there's, it takes a village is something we've heard about a lot. We need to have a good team in place. Who is the primary care doctor? Are they engaged in the care? Do they truly understand the nature of dementia? Primary care doctors have a lot on their plate. They're managing so many different things. And some may not have the experience with more of the moderate to severe cases of dementia because they may get referred out. It's really important to set these expectations and communicate. Having a dementia specialist involved, whether it's a neurologist, a geriatric psychiatrist, a geriatrician, having a mental health team. I depend on our psychotherapists and our social workers, our home health aides, therapists. These are really important key elements of a comprehensive care team. And honestly, we have to involve family and friends. Patients that are left alone to their own devices and maybe with a hired care provider just don't do as well when they have a structure in place from family and friends.
Those are really good points, Dr. Isaacson, about how to optimize care. And ideally, we keep someone at home, we keep them in the most familiar environment. Sometimes the environment doesn't work as well, and we have to think about, are there other choices? And this is where we begin talking about long-term care. And it's so important to have a good connection with the family, a good understanding of the individual with the neurocognitive changes, and that's where all these steps come into play. What do we look at in terms of thinking about long-term care? Well, how is the caregiver doing? Do they have the time, the ability, the resources to provide care? Or are they overwhelmed? Or are there overwhelming safety issues that even with the best of caregiver, it's not really going to solve? Also, does the person have enough hands-on care at home? It's not just about being there. It's about having to change the person, sometimes clean them, move them, and that can be physically challenging. Are they able to do that? Is there enough supervision during the day? No one can be on 24/7. It's just not possible. And even when you have a really good, comfortable home situation, is there enough stimulation for the person? Ideally, we want individuals to stay at home, but this comes up all the time during the pandemic. If anything, what if someone doesn't have enough activities or stimulation? They're bored, they're isolated. That's not good either. And so sometimes, even though we don't want them to have to make a move, different forms of long-term care, whether it's assisted living or a memory care community or nursing homes, can really make a positive difference for someone. Otherwise, what can you do to enhance home? Well, having aides can make a difference. Having companions, people to come in not just to watch the person, but to do things with them. And you have to, over time, consider, does it have to be 24/7 to keep someone from having to be in a nursing home? Assisted living has many different options today, memory care options as well that can provide more structure and activities. And eventually, sometimes people do need nursing home level of care, but keep in mind that it just doesn't end there. I work at a nursing home. I've worked here for 21 years. People come here and they live and they thrive and families are involved. When you look at it as just a different stage of life and you get them involved and actively engaged in different things, you can really continue to have an important lifestyle for them.
And I think it's also important to think about what resources are out there and what is the evidence for these resources. And some people may not have heard of what really this term is, but there's a term called the decision aid. So what is a decision aid? Just keeping it simple, these are things like videos, booklets, or other web-based tools that can explicitly state the type of a decision that needs to be made. It can provide information about that decision and then summarize the options along with the associated benefits and harms. And having these tools, having these resources at the ready, whether they're developed by you or your institution, or whether they're really pulled from resources online from the variety of different organizations out there, or different national caregiving organizations or the government. These decision aids can help guide a decision maker through clarifying the values they place on benefits or harms of each of the different options. And clinical practice is tough. We have a lot to talk about, and we can talk about something in person, but then you leave and because of the stress and because of the moving around and getting the person to the office, and there's so much stuff going on, you're not taking notes. Having these extra tools, I think, can really be helpful. So what are some of these areas? Well, eating and feeding options. Decision aids have actually been shown to reduce decisional conflict and increase conversations between the caregivers and those in charge of care planning. They're also been shown to be more effective in increasing discussions in nursing homes with lower staffing levels, and that's really critical, especially during the pandemic. The place of care. Decision aids can actually reduce conflict and increase conversations between caregivers and care supervisors, and really lead to more effective discussions in nursing homes with lower staff levels as well. So these are, there's a common theme here, and we can, truly make the situation better by using these tools. And then finally, what about the goals of care? A video aid together with a structured meeting. So again, a blended curriculum where you meet in person with a social worker or care provider or educator, nurse, with a video aid together. And this is something that we often do in our practice, has actually been shown to improve communication between caregivers and professionals and improve concordance on goals after 9 months. And there's actually a greater proportion of participants that chose comfort care as a goal after using a video decision aid compared to just a narrative alone. And these are important things, and these are really difficult conversations. So, having the reiteration of the content and having the multimodality where someone can view this on their own, view this again when it's the right time, rather than when they're trying to manage the patient with Alzheimer's, the person with Alzheimer's that's next to them, whether they're managing the day-to-day tasks. If they ever have a quiet moment, they can go back and they can learn and they can rewatch.
Yeah, and there's such an explosion of different aids like this recently for caregivers, for patients, for clinicians that, there's no shortage of resources. In addition to that, remember that you can draw upon so many different community-based resources. There are home health agencies that can help guide who's going to be best to be in the home with someone, make certain that it's a good match for the person. During the day, there are adult day programs that people can go to, adult education programs. You have to see really what someone's interest, what level are they at, is there adequate supervision for the programs, but it keeps them busy during the day. It gives them a sense of purpose and meaning. Sometimes having companions who can read to someone, take them places, it gives the main caregivers a break. It also keeps someone involved in activities that give them meaning and purpose, keep them from being too bored. And finally, there's so many different organizations, the Alzheimer's Association, the Alzheimer's Foundation of America, and related organizations that provide a tremendous number of resources for clinicians and caregivers and people involved in this to help us in all these decision making, to give people the type of support that they need. So we hope that this module series has been informative and helpful. It's been our honor and our pleasure to present this to you. Again, I want to thank my friend and colleague, Dr. Isaacson, for joining me for these modules. A reminder to those who have listened to please complete the post-activity questions. And with that, this completes the series, Caring for Patients with Early Alzheimer's Disease, Expanding Current Knowledge, Providing Hope for the Future. Thank you so much.
Thank you, Mark.